My name is Anna Focek-Tressiter. I am the program director, I can't wonder, Mike's here. I'm the program director for the Eastern Washington University Masters of Public Health program. We are thrilled to see you all here. I kind of thought once the snow started falling that this was going to be an empty room, so thank you everyone for turning out today. We are doing this a little differently. Our speaker is not with us this time, and so she's with us in virtual mode. But these grand rounds are something the Masters of Public Health program does every month to raise the visibility of critical public health issues. They're at the forefront of discussion these days, and maternal mortality, certainly, it's hard to escape it through all the news. Serena Williams and Beyonce's well-documented issues when they went through their pregnancies. We have a lot of exposure to information around what is going on and how is this happening in the United States. A few housekeeping issues before we get fully started. We have these grand rounds every month, so please do keep in touch with us as you signed in. We'll keep you in the loop when we have them. We'll be skipping next month since the campus will be closed and we'll all be on break, enjoying that greatly, I'm sure. And then we'll come back with 2 in January, and so we'll talk about that more at the end. So what I'm going to do a brief introduction just because we want to set the stage as to why this matters. And this is a really critical public health issue because how do we get to the point when we have a country that has all the healthcare resources, all the expertise, a plethora of hospitals and health systems with state-of-the-art resources, and yet we are the only developed nation where women are still dying during pregnancy. It's insane. And so the quote here, the United States is the only industrialized country where the rates of maternal deaths have actually increased and not decreased. So young women actually have a higher risk of dying during pregnancy and childbirth than their mothers did. I didn't think that was our intention with the development around our healthcare system, right? We do an amazing job with infant mortality for sure. However, maternal mortality has been increasing at an alarming rate for a system and a country that has so many resources. And it's not just a matter of access. Usually we're like, oh, well, maybe it's just the Medicaid populations and it's people who don't have access. It's everybody. This is one of those issues that's an equal opportunity issue. Okay, it's affecting mothers of all ages, races, education levels, healthcare access. However, we do have some very serious racial disparities when it comes to maternal mortality. African American women in particular have 3 to 4 times greater likelihood of dying in childbirth than their white counterparts. So not only are we dealing with an issue that shouldn't be an issue in a country like ours, we're dealing with a tremendous disparities of people who are accessing care in our hospitals. So as I was kind of getting a sense, Serena Williams was really at the center of attention for a while with some of the issues that she faced when she was having her first child. And I found a nice little run of stories. And take a look at these comments and tell me what you think they have in common. We often feel lonely on this birth path. And these are all women who had close calls but survived. I had to diagnose my own life-threatening brain bleed. And this is a physician, a respected physician in a large, respected healthcare institution. And she was still not believed when she told her providers that something was wrong. I felt dismissed and I felt dismissed throughout my postnatal care. We spent many weeks in the NICU. I was in survival mode and did not grasp it until months later. You would have thought I was a mute from Mars. So not only are the feelings of alienation, isolation, women don't feel like they're being heard in their care. And so you can find plenty of stories on very legitimate news websites, CNN for one, NPR for another, of women telling their stories of how they were neglected and ignored by the healthcare providers who are there to take care of them. Right? This is heartbreaking for us in public health because this is one of the most preventable issues that is affecting us right now. We can easily do something about this, but something's going wrong in our system. And so Alexis is going to talk to us today about what's happening in Washington State, how severe is this issue here, and what strides is the state doing to make changes? Because the other side of this coin are, how are hospitals and health systems looking at these deaths? Are they investigating them? And then are they doing anything to improve the services that may have caused some of the complications that caused the death? My first C-section, the wound popped open due to intense coughing as I endured as a result of an embolism. I returned to surgery where the doctors found a large hematoma and swelling of clotted blood in my abdomen, and then I returned to the operating room for a procedure that prevents clots from traveling to my lungs. And when I finally made it home to my family, I had spent the first 6 weeks of motherhood in bed. That is certainly not the picture we're given of childbirth in the days after. But unfortunately, this is a reality for many women. And when we talk about maternal mortality, the deaths count, yes, but it doesn't necessarily capture all of the close calls and ER visits and clinical visits that are also part of those statistics. And so that may also provide us more information on where the issue is in our system. All right, so with that, I'm going to turn it over to Alexis.
Okay. Thank you. Thanks so much for having me, you guys. Let's see, so my name is Alexis Bates. I have been here at the Department of Health since 2016, and I'm the coordinator of the Maternal Mortality Review here at the Department of Health. My background is in social work, and I have a master's in social work, and I worked as a medical social worker and a discharge planner most recently before I came into the public sphere. So today I'm going to share with you the findings of our first maternal mortality review, the first formal one here in the state, and we reviewed deaths from 2014 and 2015. I'm going to tell you a little bit more about what to expect today, but I just want to just take a moment to acknowledge the women and the families who are affected by maternal mortality or who are affected by near-miss events. We do this work to prevent these deaths and to prevent these things from happening, because when women die, they leave behind their babies and their children, and communities are stronger with women and mothers in them. So today I'm going to talk to you about maternal mortality in Washington, kind of what we do here at the Department of Health to learn more about what's going on in Washington. I'm going to tell you about the review process, and I'm also going to tell you about the first formal review findings, and what we've been doing since we've had the maternal mortality review. I do want you guys to keep in mind that we have limited information to draw conclusions from, because we only have 2 years of data that's been collected and analyzed with the intensity that we have done just recently. And so we can't yet make a lot of concrete statements to compare ourselves to the rest of the nation. And I'll talk more about that in just a little bit, but I do want you to keep in mind, so if it seems like I'm staying high level, or if I'm not really getting down into the nitty-gritty, there's a reason for that. So first I'm going to talk to you guys about, and the other thing is, before I get started, if you guys have questions, if you wouldn't mind just holding them until the end, I'm going to try to leave lots of time for your questions. So I should get done through the slides in about 30 minutes, so at about 4:45, 4:50, so we should have plenty of time for questions. But I do have a lot to fly through, and I want to make sure to get you all the information. So just hold your questions till the end, and then I'm happy to answer them. So as Anna said, the maternal mortality rates in the United States are among the highest of all developed nations. And there's been a lot of news media calling attention to this issue over the last 3 or 4 years, but really a lot has increased recently in the last year. And the news has really highlighted that women of color and women from underserved communities are really most affected by maternal mortality. In reality, the rates have actually been rising in the United States since the 1980s. So they have been going up for a really long time after nearly 100 years of declining. There's a couple of schools of thought about why this is happening. There's an idea that perhaps the rise in chronic disease and in mental illness throughout the United States is a contributing factor to the rise in maternal deaths. There's been changes in how we actually collect data and analyze data about maternal mortality, and so perhaps we're getting better data and more data, and so the rates perhaps have been high for a lot longer, and we just didn't know it because now we have better data. And then also there are rising and health inequities throughout the United States. Inequities surrounding healthcare coverage and income and race and ethnicity and rural versus urban. And those disparities and inequities have been widening, and that could also be a factor in why these rates are going up. Maternal mortality is a rare event, but it is a quality indicator of women in maternal health care and healthcare services. And on this slide, I have 20, but really some researchers think that for every maternal death, there's 50 or more women who are affected by a near miss event. So they almost die during pregnancy or after, in a way that's related to the pregnancy. And it's, I think, 60,000 or more women a year are affected. And near miss events, they're called severe maternal morbidities, affect women, their physical person, they affect them emotionally, they affect them socially, and there's a huge economic burden related to having health problems following a pregnancy, at all, but following a pregnancy. So here at the Department of Health, back in 2015 and 2016, some advocates, not here at the department, but from other women's health organizations, they championed Senate Bill 6534. Which was the passage of the Maternal Mortality Review Law. And they did this to kind of figure out, there was noise that the rates in the US were going up, and we wanted to know what was going on here at the Department of Health. Maternal mortality, any kind of death review is resource intensive, but death reviews are essential to figuring out, not only collecting data, but to figuring out how deaths are preventable and what were the issues that could have been prevented. So maternal mortality reviews or any kind of death review really helps us get at the root cause of death. The Department of Health had been conducting informal maternal mortality reviews with limited information, and so they weren't really able to get at preventability and make recommendations to prevent the deaths. They were really doing surveillance on what the rates were in the state. So the law was established in 2016, and if you're a law junkie, you can look up the codified law at RCW 70.54.450, and this slide deck has links to both of those. Washington is only one of a handful of states that has a maternal mortality review law, but there are other states following suit. The law directs the Department of Health to conduct multidisciplinary maternal mortality reviews to identify factors surrounding the maternal deaths and to make recommendations for health care and policy changes to improve women's healthcare services. So our job is not only to figure out how we can prevent maternal deaths, but to improve the healthcare services for women in the state. The law provides the Department of Health with the authority to obtain records related to death. So medical records, vital records, birth and death certificates, coroner and autopsy records. And then it protects those records and the panel members from public records disclosure and from any legal proceedings. So everything we collect is confidential. We share limited de-identified information with our panel, and we share information in aggregate to the public. The role of the review here is an educational role. It is not punitive. So we are not looking for to point fingers at anybody. We're looking at ways we can do quality improvement and make the system safer for women. So in December of 2016, we impaneled 60 women's health professionals to our panel. Some panel members help us review the cases and answer key questions. Some panel members are experts in a field that we consult with, and some panel members help us on the process. So each person kind of does a different thing, but we have all different types of disciplines from all over the state. So we have maternal fetal medicine, family providers, nurse midwives, licensed midwives, social workers, genetic counselors, nurse managers. We've got lots of people associated with women's healthcare on the panel. And then the law requires us to complete and submit a report of findings every 2 years. And our first report was submitted last August, and our next report will be submitted this coming summer. I'm not going to bore you with the process of our work. I really love process, and I could talk about it for hours, but if you want more information, our process is outlined in great detail in our report, which is available through our webpage, or you can always call me or email me, and I'm happy to chat with you about how we do it. But basically, a death review is very complicated, and we've divided the process up into 4 parts. In the first part, we work with vital records to identify all of the maternal deaths in the state. In the second part, we work with a subcommittee of our panel members to identify which deaths could have been directly related to the pregnancy. In the next stage, we look at all of those deaths. So we look at all the records we can get on those deaths that could be related to pregnancy, and we figure out which ones were related to pregnancy and which ones were preventable. And then we prepare recommendations for systems changes for legislators. So those are kind of the 4 steps of the process. Before I go further, we're going to jump into the data here really quick. There are some key definitions that I want to go over with you really quickly. It's super confusing, and it's confusing here for us, and it's confusing throughout the nation, and that's because there's a lot of people use a lot of different definitions. In the state of Washington, we use these definitions, and we are trying our best to align ourselves with the Centers for Disease Control with their recommendations. So when I talk about a maternal death is the death of a woman during pregnancy or within a year after the end of pregnancy from any cause. When I talk about part of the review process we do is we work to figure out which deaths are pregnancy related and which deaths are not pregnancy related. Pregnancy related deaths are deaths of a woman during pregnancy or within the first year after the end of pregnancy from a pregnancy complication, a chain of events initiated by pregnancy, or the aggravation of an unrelated condition by the physiological effects of pregnancy. In the media and in the news, what we are hearing about when people say maternal death is generally they're talking about deaths that are directly related to pregnancy. So maternal deaths are the umbrella that include all the deaths of women that were pregnant in a year, and then it's pared down into those deaths that are pregnancy related. So the rates that you hear in the news and in the media articles, they're really talking about pregnancy related mortality as opposed to maternal mortality. Maternal mortality is all encompassing. Okay. And then as part of our review process, again, I'll be talking about pregnancy related deaths. So those deaths that were determined by the maternal mortality review panel to be related to pregnancy, and pregnancy associated deaths. And those are deaths that aren't related to the pregnancy, but they're still maternal deaths. So in Washington state, these are our rates of maternal mortality, so all maternal deaths and pregnancy-related mortality since the 1990s. And our rates have been pretty stable. So unlike the rest of the nation, which in aggregate is going up, our rates are staying about the same. We have a spike up and a spike down periodically, but they're really about the same. Our pregnancy-related mortality rate is about 9 deaths for every 100,000 live births. So that's how the rates, when we hear this idea about rates going around, they're really talking about a ratio, the number of deaths for every 100,000 live births. So when we compare Washington to the rest of the United States, it's hard to compare because each state collects data differently. And the CDC, the information that they're publishing about pregnancy-related mortality rates, their data is different than ours. We have better data because we have more information. But if we are going to compare, in the US, there's about 700 women who die each year from pregnancy-related causes. And that means their rate, the US's rate is about 17 pregnancy-related deaths for every 100,000 live births. In Washington, we see about 30 maternal deaths each year. And that's really about 9 pregnancy-related deaths, 9 or 10 pregnancy-related deaths each year. And our rate is about 9 deaths for every 100,000 live births. The live birth rate in Washington is sometimes it's about 89,000, sometimes it's about 94 or 95,000, maybe a little more, a little less. So we have right around 100,000 live births. We rank about 17th in the nation based on this, but that's still really higher, even 9 deaths a year, pregnancy-related deaths a year for every 100,000 live deaths is still higher than most developed nations. So we looked at deaths from 2014 and 2015 in this last review, and just keep in mind these are small numbers. So we think we might be seeing things emerging in the data, but we can't say for sure until we have about 5 years of information. So what I'm sharing with you today is really just a description of the cohort, so it's just what that cohort looked like. So we had a total of 69 maternal deaths for the 2 years, and of those deaths, the Maternal Mortality Review Panel found that 16 were directly related to pregnancy. And you can see at the bottom the total number of live births for those years. So when we look at the leading causes of death, we're looking at the underlying cause of death, so the ultimate reason a woman died. This is for the pregnancy-associated deaths. So these are the deaths that were not directly related to pregnancy. The leading cause of death were those deaths related to injuries, so motor vehicle accidents, followed by accidental drug overdose. And then cancer and homicide and suicide, and then seizure and cardiac related deaths. For deaths that were found to be related to pregnancy, so these are the deaths that the news media is really focused on. There were 16 total for the 2 years, and I think 1 year was 8 and 1 year was 8. Or I can go back and look. So 1 year was 9 and 1 year was 7. I almost said 8 plus 7, that's 15. 1 year was 9 and 1 year was 7. So the leading cause of death for both years were deaths from hemorrhage. So that's from bleeding too much, followed by hypertensive disorders of pregnancy. So sometimes people hear it as preeclampsia or eclampsia. Followed by amniotic fluid embolism and infection and sepsis. This is pretty similar to what the rest of the United States sees. Leading causes of death are usually hemorrhage and hypertensive disorders of pregnancy. So of those deaths, the pregnancy-related deaths, so the 16 pregnancy-related deaths, the Maternal Mortality Review Panel decided that 50% of those deaths were preventable. 37% were not preventable. So there was nothing anybody could have done at any point to prevent those deaths. And 12 of them, the panel could not decide whether or not they were preventable. So we'll look a little bit about demographics for this cohort. We have on these next 2 slides, I have pregnancy-associated deaths, pregnancy-related deaths, and then for comparison, we have the total live births from the same time period. So I'm going to focus on the pregnancy-related deaths, and I think most of the time it's the information in the middle, and on the right is the information for the total live births, and then on the bottom is the key. So this is the percentage of deaths, of total deaths. So for 2014 and 2015, there was a large percentage of the pregnancy-related deaths were to 30 to 39-year-olds, followed by women who are aged 20 to 29. And you can see the pregnancy-associated deaths really looks just like the total live births. And so we can see there's definitely, it seems like for this cohort, there was something going, the women who are aged 30 to 39 were disproportionately represented for this cohort. So we're going to look at percentage of women by race and ethnicity. We have, again, total live births on the far right, pregnancy-related deaths in the middle, and pregnancy-associated deaths on the left. And again, this is just the percentage. The pregnancy-associated deaths and the total live births look somewhat similar. And then you can see the pregnancy-related deaths. There's definitely there's some differences going on in terms of race and ethnicity when we compare that to what's going on to the total live birth. We look at education level. Again, total live births on the right and pregnancy-related births in the middle. The gray bar is for some college or no degree. The blue bar is for high school or GED completed. And the pink bar, the kind of pinkish gray bar, is for 12th grade or less, but no diploma. So the total live births and the pregnancy-associated births, again, look pretty similar, a little bit different, but same trajectory. And then the pregnancy-related deaths, we do have, there's some differences there. And so we'll see in a few years if that stays the same or if something else, if it looks a little differently. So we also looked at some other factors, and the ones I'm presenting today are the ones that are most directly related to our recommendation. So when we looked at the deaths, and again, this is just the pregnancy-related deaths for the review, we did see in the case reviews that an overwhelming proportion of the deaths, the women were overweight or obese. And in fact, most of the women had a BMI greater than 40. 30% of the women had a BMI greater than 40. 94% of the women who died from pregnancy-related causes were overweight or obese. So, and these are BMI categories of overweight and obese. So when compared to the total live birth, they were disproportionately represented for this cohort. We also looked at the length of time that women died from related to their pregnancy. The bar in that pinkish gray is the women who died from pregnancy-associated deaths, so deaths that were not related to pregnancy. And there's a bell curve. There were a lot more deaths during pregnancy, and then that went up again as we got towards the end of the year. But when we look at the pregnancy-related deaths, we definitely see that something was going on right over there on the left, that most women died the first 7 days after their pregnancy ended, and followed by they were pregnant at the time of their death. We also looked at some healthcare coverage information. We didn't have information on income, so we looked at healthcare coverage as a proxy for income, and really we were trying to get at who of the women were at or below the poverty level and who weren't. On the right-hand side, that's healthcare coverage for women in Washington who had a live birth for 2014 and 2015. And about 50% of those women, just under, are covered by Medicaid. Other payers include private insurance, Department of Defense, or people who are uninsured. And I don't have those separated out. We just wanted to look at people who are on Medicaid, public health insurance, and people who weren't. And when we look at the pregnancy-related deaths, we were really happy to see that everybody did have some form of health insurance. As a social worker, I was very happy to see that, but 75% of them were covered by public health insurance. So we look at that as 75% of the women were living at or below the poverty level. So we see that group of women is disproportionately represented in this cohort. But it's also, I think Medicaid coverage also can be considered a protective factor because it does indicate that women did have contact or connections with healthcare services to get them the care that they need. So ideally, they were meeting with somebody who helped them get their Medicaid. So that makes me think that they were getting access to other services that they might have needed as well. So we don't want people to think that having Medicaid is a risk. That's not what this is saying. We're just saying that as an indicator of income, it does look like the majority of the women were living at or below the federal poverty level. And then finally, we looked at whether or not women received an autopsy. An autopsy is a really integral part of any kind of death or fatality review. But we also wanted to understand more of what was going on with that. When were coroners taking jurisdiction? When weren't they? When were these deaths being reported? And we learned that the majority, when women were dying in hospitals, their deaths were not being reported to local coroners, and that's totally legal. That's they don't have to. But when we reviewed the deaths, there were some times where the panel members disagreed with the cause of death that was listed on the death certificate for deaths that occurred in hospitals. So it's just something that we're taking a look at into. So now I'm going to talk about the contributing factors and key issues. So the information that I showed you above came from when we pulled data, and we're looking kind of at data in a statistical and an analysis way. But next what I'm going to show you is the contributing factors and key issues and the recommendations. So these were developed by the panel, these were identified by us and the panel members during the review of the cases, and then combined with the data that we found. So we organized contributing factors in the same way that the Centers for Disease Control organizes them. So patient factors, provider factors, facility, systems, and community factors. So we found contributing factors to deaths at all levels. So these are the things that the panel members saw in the case review, that if one of these things would have been changed, perhaps the woman's life her death could have been averted. And due to the small numbers, we didn't go into specifics because we wanted to make sure that none of our information could ever be used in litigation. So I don't have specifics, I just have this information in aggregate. But as we get more information, we'll be able to share more specifics when it can't be, when a specific piece of information can't be connected to a specific person. So there were factors, so personal and religious beliefs affected women's healthcare and their healthcare outcomes. Their lifestyle choices, and by lifestyle choices I mean their diet, their use of substances, so of alcohol or drugs or tobacco. Whether or not they had social support, there seemed to be a lack of social support for many of the women, where they just didn't have family and friends during pregnancy or after pregnancy to help them out. Comorbidities and chronic disease, including mental illness, but also chronic illness like obesity, and having people's basic needs met, making sure people had a home to go home to after they had a baby. At the provider level, there were delays in care, in diagnosis, and in treatment and intervention. There was some medication management and dosage, and social biases and discrimination. And I want to say, for the providers, a lot of this stuff is easy for us to see in hindsight and in looking at the cases. So while we see that there's delays in care and in diagnosis and in treatment and intervention, when the providers perhaps were doing their job, to them things seemed like they were doing what they could do. So I want us to keep that in mind. We have the ability to see the whole picture, so it's easy for us to identify areas that could have been done better or done differently. So at the facility level, we saw a need for standardized protocols for maternal emergencies and maternal care, better language services, and there was a lack of just a capacity for maternal care. Different hospitals have different capacity to care for women and babies, and to care for obstetric emergencies. Some hospitals are fine to have babies, but they can't really handle obstetric emergencies as well. And then there were systems level issues, information sharing, delayed transfers due to bed availability in our state. And as a social worker, I know that problem all too well. When you need to transfer somebody to a higher level care and there just isn't a bed available at another hospital. Providers just not knowing that women were pregnant or had been pregnant, and pregnancy or being in the postpartum period means different things. So if a woman goes in with a headache and she just had a baby a few weeks ago, a headache is a lot different than if a woman who's not pregnant or hasn't been pregnant goes into the ER for a headache. You just consider different things. So access to postpartum support services like in-home nurse visits, and then variation in autopsies. So just inconsistency in the autopsies. So there were some key issues that emerged from this cohort, and we don't know if these are key issues across our state. We do know that for these 2 years, these were the issues that we see were going on. There was definitely a high proportion of women who died from pregnancy-related causes who were overweight or obese. While we didn't look at these deaths during this review, 22%, I think, of the deaths were from suicide and overdose, which we think is a high number for this population. There seemed to be a gap of care and a lack of follow-up services for women, especially in that really early postpartum period, so the first week or two after women had babies. Like I said, there was inconsistencies in the autopsy, so whether an autopsy was performed, or whether a death was reported to the local coroner for autopsy and whether an autopsy was performed. And we see emerging disparities Again, with only a few years of data, there's only a few number. We're talking about 16 deaths. For us to draw any conclusions about disparities at this point that are going on across the state. It's really hard for us to make that distinction, but we can say that we do see some emerging disparities. So the panel came up with 8 high-level recommendations, which I'm going to kind of fly through so I can tell you more about what we've been doing. So one of the recommendations was to improve care for women with a high body mass index. And so that is really to develop a best practice of care for women with a high BMI during pregnancy and postpartum. Since then, we found out that this kind of guideline doesn't really exist. To promote standardized protocols for ectopic pregnancy. To expand healthcare coverage for all women in the state. The Affordable Care Act expanded coverage for women in the state, and we want that to stay, especially given changes in federal policy and with the federal administration. We really hope to see that expansion stay in place. We also have a recommendation to expand Medicaid to comprehensive coverage through the first year post-pregnancy. Improve access to mental health services, specifically mental health services tailored for pregnant women and moms. And then have postpartum depression screenings done by newborn providers during well-child visits. And I do believe that that is a reimbursable, that is paid for now. So the state passed legislation or policy to make sure that that can happen. Improve postpartum follow-up care, and this is specifically during that first week or two after women have babies. Our recommendations are to refine those recommendations. We suggested facilities or providers call mom within the first couple of days postpartum, do a 24-hour check-in plan for mom for the first few weeks. We're promoting in-home nurse visits within that first week postpartum. And then we are promoting other organizations and groups who are doing really good work for women postpartum. Improve health equity and address social determinants of health. Health equity issues and social determinants of health are really indicators of health outcomes and are affecting women in our state, regardless of what maternal mortality is. Health inequity affects women throughout the country, and social determinants of health really have a huge impact on maternal health care and on maternal mortality and infant mortality. So when women have good housing, when their basic needs are met and they have access to healthy foods and education, moms and babies do better. And then improve death investigation and autopsy. And so we actually have, we are asking legislators to consider asking hospitals to report all potentially pregnancy-related deaths to local coroners, and then all of those deaths receive an autopsy. So since the maternal mortality review, we've been working with our Washington State Perinatal Collaborative, which is a group of volunteer women's health providers from around the state, to begin implementing these recommendations. And I want to preface this, we do this in our extra time, and we, all of the members of the Perinatal Collaborative are volunteers, so the work has been really slow. But part of what we've been doing is sharing the information from our review and also continuing our review to get it out there so people can take the report and take the recommendations and implement them into their own work. But we've been working with our Perinatal Collaborative to address mental health in women in pregnancy and postpartum care, and have been promoting and working on group prenatal care, family-friendly residential settings, so for substance use treatment and mental health issues where women can take their babies with them when they're receiving treatment, and postpartum depression screening, reimbursement, and well-child checks. We, like I said, we're trying to address the inconsistencies in the death investigation and autopsy. We have an agency request for legislation change, and where we're going to be requiring reporting and autopsy. There's a group of panel members and perinatal collaborative members who are working on developing the nation's first, or one of the earliest, best practice and guideline for care for women who have a high BMI and some quality improvement to roll that out. And then we've been working with partners to see how we can improve maternal follow-up care. And we've been working, one of the work groups is working on creating a guideline schedule for women who are high risk. And we started for women who have hypertension disorders of pregnancy. So when do women need to come in and see their provider and have their blood pressure checked after they have a baby during that first year? And so I was asked, people in public health want to know what they can do. And the first thing that I say, and this is probably the social worker coming out in me, is addressing social determinants of health. Programs that address increased access and increased equitable access to education, healthcare, housing, and food security is number one. Those things are protective for moms and babies and families and communities. And when people are healthy, then when moms are healthy, babies are healthy, and that eases a burden on communities and on the healthcare system and on the state. Addressing health equity and barriers to care. So the best thing we can do when there are inequities is to address the reasons women can't get the care they receive. Making sure they can afford healthcare coverage and they can afford to go to providers. Make sure their transportation is covered and they have transportation. Make sure that they know about what's going on. Do moms know what's going on? Do they know what to look for? Do they know about prenatal care? Do they know about taking prenatal care vitamins? And do their family members know? And then getting women in with their care providers. And then really as public health, as emerging public health practitioners, considering the data and findings that I presented and that the media has said, and how you would apply our recommendations and what you see in the data to your own work. So thinking about what in your own work could address some of the issues we've seen the last 2 years. So I'm right at 4:45 according to my clock. I'm happy to answer questions at this point.
All right, thank you. Ooh, sorry about that. Here's how questions will work. You all have buttons on little pods in front of you. If you hold that button down, the camera will come to you and your microphone will turn on. Ask your question, and then when you're done asking your question, let go, and the camera will come back to me and Alexis. Don't worry, you're just small on the screen. You don't take up the whole screen to those. So we do have folks that are online. And so for those who are watching our stream, you can go to the Q&A section and type in your question, and I can pass it on to Alexis. Do we have any questions?
Hi, Alexis. Thank you so much for your time this evening. California has implemented a system that requires hospitals to report key indicators related to maternal health and mortality. Doing so enables the information to be compiled into a database and for evaluation and specific improvement measures. For example, hospitals that might possibly need to
You know, I'm sorry to interrupt. I'm having a really hard time hearing you. I'm only getting every few words.
Hello? Hello?
Oh, that was better.
Okay.
That's better.
Try this again. So California has implemented a system that requires hospitals to report key indicators related to maternal health and mortality. And doing so has enabled them to compile information into a database and for evaluation and specific improvement measures. One example, for instance, is hospitals that might possibly improve on hand washing techniques to reduce infection rate. Do you know of any legislation in Washington that is addressing something similar? So like a statewide database where hospitals are required to report information like infection rate and things of that matter?
You know, honestly, I don't know. I can definitely ask. I work closely with a nurse consultant who might know, or she might know the person we have to talk to. And so I can definitely ask her and get back to you on that. I do know on the horizon, Washington State is joining AIM, which is the Alliance for Innovation in Maternal Health, I think, it's funded through ACOG and somebody else. And it's kind of like, we know about California. California does a really great job. They have a lot of money they're able to dedicate to their quality improvement. But AIM is similar, where it will be, the nurse consultant I work with will be working with the Washington State Hospital Association. It's a little bit similar, except it'll be a voluntary basis. It won't be, there isn't any legislation surrounding it. But we will be, as part of that, hospitals will be asked to submit certain key indicators, depending, and then so we can collect data on that. I don't have all of the details on that. My knowledge base is really on the maternal mortality review, but I can definitely get back to you if you if Anna can send me your email address, I can connect you with Tiffany Buck, is her name.
Thank you.
You're welcome. I'm sorry.
Any other questions? Anybody online?
I have a question. Could you talk a little more about some of the best practices you're developing for women who have high BMIs who are pregnant?
Yeah, you know, I'm actually, so we, sorry, there's an echo.
Oh, sorry, that's me.
The Perinatal Collaborative, we divided up into work groups to work on this, and I'm not on the work group who is developing the best practices for women with high BMI, but my understanding is at our last meeting this last fall, they have a basic guideline, and whenever we do something to come up with guidelines, it goes through a pretty intense vetting process where a lot of people take a look at it to make sure everything we're saying is true. And so I believe it's going through that process, but once it's done, it will be available. We have a web page that we host the products of our work groups, of the things that we're doing, and it will be available there. So if you want, you can email me and I can put you on my email list, and whenever we post anything like that, I send out an update.
Great. Any other questions for Alexis?
Hi, I was wondering if you compared midwives to doctors in your data of.
We didn't. All of our information, we know at the Department of Health, so those of us working on the team, we kind of know what providers were doing what and what hospitals people were going to, but unless we see an emerging pattern that we think, well, we only have a couple years of data, so we don't know if anything we see in the 2 years of data is a trend or not. If we did see a trend, we would take action here at the Department of Health, but we don't share any of that information with the panel members because we share everything is de-identified, and part of de-identifying is to make sure to protect confidentiality and to protect people's identities. So we don't share provider names or locations or places. We don't share facility names. It's just hospital A or hospital B or this provider. And we also don't share provider type unless it's absolutely pertinent, because we don't want to bias providers in any way. The only time a provider type is shared is if it's an obstetric provider or an emergency room provider or like a social work provider. That's how we kind of differentiate. We don't say a maternal fetal medicine, we just say a specialist. So yes, so I don't have an answer to that question. I'm sorry, I'm like 3 for 0 here.
I have one final question. Do you pool data nationally? Is that something that AIM is going to do, or yeah?
Again, I don't know the specifics on AIM. I do know it's awesome. Tiffany has more information on that. We are, national data is interesting. The CDC pools national data from vital records. So they pull information across the country and about maternal mortality and pregnancy-related deaths from what they find on vital records. So that's based on the cause of death that's on a death certificate. But they don't have as much information as we have. So we have the ability to refine those deaths. So they are reporting probably more deaths than what are actually, more pregnancy-related deaths than what are actually going on. So in that way, they are kind of pooled, but I don't know if AIM pools them. But what we're trying to do is right now our law says that we can't share data. So we, as part of our agency request legislation, we're asking to be able to share data with the CDC. And then the CDC is working on pooling data from states that have maternal mortality review panels, because that's different than what it's called the pregnancy mortality surveillance system. That's different than what the pregnancy mortality surveillance system is, just two different kinds of data sets. So hopefully we'll be able to pool some information with the CDC, but it'll be high level information like number of deaths, cause of death, probably some demographics and some of the contributing factors. It won't be as detailed as what the young woman who's talking about what's being done in California. It won't be like key indicators. We don't have that capacity right now.
Great. So Charlotte, you can go ahead and ask your question. Then we have one question from an online participant.
There was a New York Times article last week that suggested that mothers' health might be being held sort of against their baby's health, and I was wondering if there's anything in the Washington data that suggests this.
That mothers, what? Can you say that one more time for me?
The article was about how mothers are sort of being blamed for their children's deaths, or there's so much attention being drawn to the baby that the mothers are sort of are being underobserved.
Yeah. So that's one thought on why maternal mortality rates have gone up, is that after the 80s, there was a lot of focus on improving infant mortality. And so people have lost sight of moms and mom's well-being, especially after mom has a baby. When moms are pregnant, everybody's attention is on mom and her pregnancy. And then after babies are being born, the attention kind of falls off of mom. And that childbirth is this easy process and mom's okay, of course. So there is an idea that that was going on and that just the attention fell off of mom. And that's part of why the rates were gone up. If that's going on here in Washington, we don't have enough information. We just don't have enough data to say that for sure. It's hard. I'm so sorry. It's really hard with just 2 years of data with 16 deaths. It's very hard to say whether what we saw for these 2 years is a trend throughout our state or whether it's just specific for those 2 years.
Great. Oh, hold on, Alexis. We've got a big question here for you. Big society for you. So this is from Anne online, and it says, thank you for your presentation, especially for highlighting the racial and ethnic disparities in maternal mortality rates. Given these disparities and new research highlighting the role of racism in these disparities, how can we begin to address institutional racism as both a social determinant of health and a barrier to care?
So I will answer this as a social worker, is making sure that underserved and priority populations, that programs are focused on those groups. So making sure that people in your area who you know are underserved or who are priority populations, that they have access to the services that they need to increase their equity. So to make sure that they can get what they need to be healthy and safe. And it's different. Social determinants of health are across the board. So the better education people have, the better healthcare people have, the better housing they have, the better food security they have, the healthier they're going to be and the better their health outcomes are going to be. But who has access to what varies depending on where you are. So you have to think about your community and you have to target, well, target's not a good word, but you have to direct services. You have to make those priority populations and direct your services to them.
All right, we have another one from Allison online. And she asks, I'm thinking about the near misses and how we might target prevention more effectively if we had more robust PRAMS data sets for countries, or for counties, I apologize. In Whatcom County, we had 85 PRAMS responses over 3 years, which aren't enough numbers to disaggregate the data for targeted interventions. I'm thinking specifically about mental health questions. Is there any way to oversample PRAMS to get a bigger data set?
I would refer you to talk to the folks who do PRAM. So those are our epidemiologists. They would be able to answer that question. I don't know much about the PRAM survey, but I think you're probably, you're probably right. 85 responses over 3 years isn't enough information. I do know that they are always working on figuring out how to improve PRAMs and make it more useful. But I would direct that question and again, if you wanna email me, or Anna can send your email to me, I'd be happy to send it to one of the epidemiologists and they'll respond to you for sure.
Great. We have just one more question.
Okay.
I actually have two questions, but my first one is there a way for mothers to provide feedback on their care? And then my second one is, will the review board be looking at births that have doulas in attendance?
I can answer your second question first. Yeah, we look at births. We look at any, as long as we can identify a death. And are you talking about deaths of women who had a birth with a doula?
Yes.
Okay, yeah, if that happened, ideally we would be able to identify it. So yeah, we would. It might be hard for us to know whether a mom had a doula present if it's not in the records that we received. So we look at medical records, coroner and autopsy, and we look at medical records. We look at prenatal records, labor and delivery records, ER records if we can find them, outpatient visit records, postpartum visit records, and then we look at autopsy and coroner reports. Sometimes information it just isn't included, and so we just won't know. But if it is included, we would look at it, depending on whether it was pertinent to the case. Would mean we would include that information or not. A doula is a support person, and so we think of doulas as being there as providing an additional support to mom. So we would be interested to see if women were dying with the support system they need, then what else was going on, since having a support system is so important. For your first question, we currently don't have a way for mothers to provide feedback, but I'll tell you what, women have called me or emailed me just wanting to get on my email list and sharing their own stories about near misses with me. And it's heartbreaking, and I think every single one makes me cry. So we don't have a formal way for mothers to provide feedback, but I think we should. And so if anybody has suggestions on the best way to do that, would love to talk to you about it. But currently we don't, and we don't do, for our review, we don't do informant interviews, so we don't meet with families. We do everything from the record.
So that sounds like a great internship or research possibility, if anybody's taking note. Any other questions as we wrap up? So for those of you who've maybe attended before or missed one and wish you could have seen it, we have posted our behavioral health integration grand rounds and our suicide grand rounds from last month, and we will be posting this one. As Alexis had her nice resource list there, we will also be providing links to all of those resources so you can access it anytime. You can get to it through our blog at the MPH program, or we are starting our own YouTube channel. So fancy. Thank you. Thank you. But it's where you can go, and that's where we will be posting these videos. And so to keep up on that, and they'll also have a little place linking to the blog site, which is where all the resources, data sets, and a set of the slides, all the slides are also posted. Thank you all again for coming out this evening. It was great to see you all. As I said before, we do not have a grand round scheduled because nobody's going to be on campus next month, apparently. So what we're going to do is we'll invite our work shortages folks who are going to talk about our health workforce shortage areas here in Washington State. Will be joining us in January, as well as we have drinking water quality on our docket. So again, thank you for coming, and hopefully we'll see you in January. Thank you, Alexis.
Thank you. Thanks for having me.